Hello, good afternoon, good morning, good evening, and welcome. It's Nurse Richard, the Wax Wizard. Thank you for joining me. A bit of a long one this, about 15 odd minutes long. I think you're going to enjoy it though. There was some quite unusual ears. The first one, there was a bit of bleeding in this ear, not because of anything I did, but you'll see as the video progresses, so stay tuned for that. It was really tricky as well to remove this. It was, it looks quite, I'll be honest, I don't remember a huge amount about it because I think I did this procedure before I went on holiday recently. I'd forgotten all about it, and then when I had a bit of spare time to make another video, I saw this one, and I usually put a little title on the video saying roughly what it is, and I think this one was called Bleeding and Collapsed. So yeah, the first ear, there was a minor amount of bleeding in this, and you'll see what the cause of that was in a minute. And the other one was an extremely narrow collapsed ear canal, which was, they're both very difficult, but for very, very different reasons. This was the full-size tube. Now, I think this may have been a hearing aid user, because from what I remember about the patient, I wouldn't have thought they'd poked around in there. But you can kind of tell from how it looks because it's smeared around the outside of the ear canal, and it's very squashed in. So it's often a giveaway. And you might be wondering why I haven't started by peeling that away from the side. The main aim of any procedure is to cure the symptom, which is she wasn't able to hear very well. But sometimes you do have to look at it around the sides, because I've just looked at it on the left-hand side there and thought, that's kind of attached to what's further down. So in those instances, you do have to start at the edge, and it peels away really nicely, this. And I think this is when I became a little bit suspicious about what might or might not be going on in this lady's ear, because you'll just start to see reveal itself a really thick rubbery layer of dead skin underneath that hardened dead skin keratin layers, which always makes us a bit suspicious when you see it like that. I probably should have used a bit of oil maybe at this point. I clearly might like giving myself a challenge. I think we did use some in the end anyway. I was just in there and in the moment and just cracking on with it. You know, sometimes you have to stop and think, should I carry on doing it like this? Do you know? But when you're in there and in the thick of it and things are moving around, you kind of just keep calm and carry on. I've clearly thought better of peeling that because it kind of stopped, it kind of got a bit stuck. So I thought, well, let's just get back to my original plan of clearing the main blockage so the patient could hear again, of which they couldn't hear very much at all, to be honest with you, when they first came to see me. And I did need to refer this patient onwards as well, just to get this thing looked at, which you'll see shortly. Quite bright, that. No, it's because I've had the camera settings quite bright while I've been inside the ear, and as it just brought it out to the entrance, it just reflects off it, which it tends to do when it's like this. So I'm sticking with a full-size tube again there. I did have to go down to the fine end and then back up to the full-size one. I kept having to change, you'll see why. And the last ear is very difficult as well. It was so tiny and such a faff to get inside, but it's already peeling away again quite nicely, and I was expecting the other bit on the left hand side there to come away with that. It didn't. It's clearly anchored in by something. So let's peel that away from the entrance there. Again, it glares with all the reflection from the hairs, but you can change the settings, but if you can see well enough, you just carry on. It's a bit of a faff, to be honest, to keep changing it just when you're in a different part of the ear. So here I've gone down to the fine end tube, and it's at this point, as soon as I've touched that, I could feel it was rock solid. It was like tapping on a brick. You know, you could have just tapped on it, and you can just tell that something's not right underneath that. It wasn't wrong. How can I put it? My spidey senses were tingling. Let's put it that way, shall we? But it was so tough and hardened. You can see the whole thing moving a little bit, can't you? it's just not lifting up. I think I eventually had to change that fine end tube for the bigger one and get some oil in as well. And that's when things really started to move and it started to reveal itself. So what do I think it is? It's obviously hardened keratin. And like I said, when I removed it, there was a slight ulceration of the skin. I think that's coming up pretty shortly. You'll see me lift it up and there's a little bit of bleeding underneath. Like I said, it's not because of something I've done. It was clearly very attached to it and it was possibly starting to bury its way in. So I don't think it's not particularly deep. It's quite superficial. So when you see things like that, you would be worried about a canal cholesteatoma. If you don't know what that is, in simple terms, it's when you get, and it's always localised, that means in one specific area. If you get a hardened plug of dead skin, and it tends to grow and bury as more skin sheds, it tends to bury into the skin of the ear canal, initially causing a little ulcer. The skin can break and it can actually start to break down the bone behind the skin. I don't think it's that, but chances are if this had been left for a fair bit longer, then it could well have turned into one. So I'm glad she didn't see me because it's prevented. I've not turned my phone off again, what an idiot. It could have prevented it from turning into one. So I'm glad they came. Now I think again you'll see I've changed to the full size tube here just because I wasn't getting very far with the fine end tube. It doesn't have as much power. It's a bit easier to manoeuvre around when you're pretty deep in the ear. But one that was this hard just needed a bit more oomph. So I'm going to try at the top there. You obviously have to be really delicate and really careful here because that's a very sensitive part of the ear there. There's no fleshy fatty tissue underneath that, it's just skin and then bone. And if you touch that with that little steel implement, the patient wouldn't thank you for it. They would know about it. And I think it's just here, as we get a reasonable grip, you'll see it lift up and you'll see it reveal. You can already see there, can't you? It's kind of buried into it. There you go. You can see it's brought a little bit of tissue with it there. So it's at that point because I thought I don't want to risk tearing any skin, so I'll put a bit more oil in at that point. And again, now we've lifted it up, I'm going to try and get it with a fine end tube again, which again was a bit of a faff. But as it lifts up, you'll see the early beginnings of a little erosion just underneath that. Now, I was considering some forceps to pull that one out. I'll be honest, I'm always really reluctant to use forceps. I don't mind using them, but this deep in the ear, I'm always a bit reluctant. It's kind of got to be a last resort for me, especially if you sense that the patient is a bit twitchy or a bit nervous. You can just see the thick layers of dead, hardened skin underneath that, can't you? And it's clearly a bit stuck further down as well. It did take a fair amount of persuading this one. Now, ideally, what I'm actually trying to do here, unsuccessfully, I might add, is I'm trying to flatten that out the way, and I'll get a better suction grip if I can attach the suction tube to the softer white dead skin you can see under there. So what I'm trying to do is pull that to the left-hand side, let go of it, and then get it, and then stick the suction tube on the white area, which is what I'm doing now, because it'll get a much better seal, and you're more likely to be able to pull it out that way. The problem is I'm trying to get to the right-hand side of that because it's softer underneath there. And like I said, you let go of it and then you try and sneak round the side. As you're trying to sneak round the side, because there's suction still going on, the front section of it just, it's attracted to it, it's drawn to it. So it's a bit of a pain when that happens. You can get suction tubes where you can turn off the suction by, you can they come with a hole in them. So you can either put your finger over the hole, excuse me, and then that creates full suction, or you can take your finger off the hole and that reduces it somewhat. But you can see, we got there in the end. There we go. Whether there's any little fragments of anything in there that shouldn't be in there, like bits of bone, I don't think so. Like I said, it's very superficial. You can see it there, can't you? It's just took away a very, very fine layer. It's not even bled much at all. So I suspect that will, I mean, I referred it onwards. I suspect that will just naturally recover by itself, as long as the patient doesn't do anything daft like getting water in it. I've advised to keep it dry, and hopefully it should recover, and the skin should epithelii grow over the top of that, hopefully. But I'm going to keep an eye on it anyway. Last little cornflake there stuck on the eardrum. There we go. Another one safely delivered. I don't think if you knew it was a wax baby, that was it. It was like a wax cornflake. So I'm getting a closer look at this. Like I said, I don't think it's anything too much to worry about, to be honest. There's no obvious cavity. It's just a thin layer of skin that's missing from it. As this stuff was really stuck in a ear. To have a look at the second ear though. How do you think I'm going to get anything out of that? With great difficulty. Great difficulty. And they see it didn't present like that because you can often have them looking like that when there's a really nasty infection. Excuse me. And it can be really swollen, almost swollen shut. But it wasn't the case with this one. It was just because the cartilage of that part of the ear just kind of lost all its tensity and it's just kind of collapsed. So it's a no wonder that you get a blockage, because literally no earwax and dead skin can escape at all. So I've started with a fine end tube there, because when an entrance is this narrow, you don't want to risk putting the full size tube in there and then the ear kind of closes in on itself, and it would suck shut. And if it closes itself shut and the suction tube's still in there, then you create like a negative pressure in the ear canal, and then obviously that can do quite a lot of damage in there. It would pull the eardrum towards, and possibly like kind of pop it from the other side. It's quite rare that I've never actually known it to happen. I'm sure it is possible, but I wasn't getting anywhere with the fine end tube, so I've decided I do need the full size tube there, which is what I've gone to. Now, it's very blurry because it's such a narrow entrance that it's really difficult to get anything inside there without having a bit of the ear canal on either side of it. Makes it very blurry indeed, but it does get a bit clearer. But it is what it is. I don't do these videos and make them this way just to put out there on the internet. This is what I see. This is what you have to put up with sometimes. It is what it is until it isn't. But thankfully the ear canal itself is relatively normal. It's just this entrance, so it's not. I'm not going too deep with that full size tube. So like I said, I don't want it to shut in on itself, and I'm propping it open not only with the suction tube but with the endoscope as well, which is quite a similar size to the suction tube itself. There's not much difference, so you can kind of prop one side of it open with one instrument and prop the other side of it open with the other instrument, and jobs are good. And here comes, you'll see as I pull the endoscope away, to try and wrestle this out, because obviously the wax now is where the endoscope was, and you'll just see the difficulty I've had in getting these things in there. And you can just see how soft, can't you, that entrance is. You kind of have to, it's really mushy and soft, so it's hard to get that in there without a little bit of skin trying to attach to it. But yeah, one amongst my least favourite things to do when I see an ear like this. It's so difficult. There you go. I think I said in the video, it's like delivering a baby, that, isn't it? What's come out of there is bigger than the gap that you had to start with. Square peg through a round hole, I think it is the same we use around here. So the little bits that we have left, I think I'm going to do with the fine end tube. We've got the biggest one out, and so we've just got to peel it from around that corner. I don't think we're far away now. Thanks for sticking with it, by the way, anyone who's watched this the whole way through. Yeah, it was a battle. you know what? I had so many things I wanted to talk to you about as well in this video, and I made this video. I recorded me narrating it about 5 minutes ago. Just as I got towards the end, I had a coughing fit, and I thought, oh, go on, just keep plowing through. But you know, when you got a tickle in your throat, and you just have to stop. I thought I can't leave a video of me narrating with having a coughing fit in the end. I did think of chopping it up and recording the last couple of minutes, but trying to remember what I said, absolutely no idea. I never plan any of these. If anyone, some people do ask me, you know, do you make a plan to do 2 takes? Where's your outtakes? I never do any outtakes. And that was, having said that, I obviously did do that time, but not because I messed things up, just I literally couldn't speak anymore. That's why I might sound a bit hoarse or a bit husky at the moment. Must be coming down with something.
A little surprise.
Anyway, you can see a bit of evidence. That's not an active perforation, that. I think it's an old healed perforation, that one. I did ask them if they remember having one. They don't remember having one at all, but they're certainly happy to get all that out. Anyway, I hope you enjoyed that. Thanks for sticking with it. I do appreciate it. If you did like these videos, then feel free to follow and subscribe to the channels. But for now, take care of yourself, and I'll see you soon. Ta-da!